The medical community has officially moved away from the term non-alcoholic fatty liver disease, or NAFLD, adopting the more precise label of Metabolic Dysfunction-Associated Steatotic liver disease, or MASLD. This change is not merely semantic. It emphasizes that the liver issue is a driver of systemic metabolic health rather than a diagnosis of exclusion. To diagnose MASLD, a clinician now looks for evidence of hepatic steatosis, usually seen on ultrasound, combined with at least one of 5 specific cardiometabolic risk factors. These include a body mass index over 25, prediabetes or type 2 diabetes, hypertension, elevated triglycerides, or low HDL cholesterol. This framework acknowledges the complexity of the condition, even creating a category called MET-out for patients who have these metabolic risk factors but also consume moderate amounts of alcohol. Once the diagnosis is established, the focus must shift to identifying those at risk for advanced fibrosis, which is the primary driver of liver-related mortality. While universal screening is not recommended, high-risk individuals, such as those with obesity or type 2 diabetes, require a structured assessment. The first step for primary care clinicians is to calculate the fibrosis-4, or FIB-4, index. This simple calculation uses age, platelet count, and liver enzymes to triage patients. A score of less than 1.3 offers a high negative predictive value, meaning these patients can generally be monitored in primary care. However, those with indeterminate or high scores require a second-line non-invasive test, such as vibration-controlled transient elastography, often known as a fibroscan, to measure liver stiffness and determine if a referral to a hepatologist is necessary. It is a critical clinical error to focus solely on the liver when managing these patients, because cardiovascular disease remains the leading cause of death in people with MASLD. The condition is an independent risk factor for heart failure, arrhythmias, and atherosclerotic disease, driven by the same insulin resistance and chronic inflammation that damage the liver. Therefore, management must be holistic and aggressive regarding global cardiovascular risk reduction. This means prioritizing strict blood pressure control and optimal glycemic management. Furthermore, clinicians should not hesitate to initiate statin therapy for dyslipidemia, as it is proven safe and effective in this population, despite historical concerns about liver enzymes. While medications play a role, the cornerstone of treatment remains lifestyle modification, specifically weight loss. However, the targets are ambitious. While losing 5% of body weight can reduce simple steatosis, resolving metabolic dysfunction-associated steatohepatitis, or MASH, requires a sustained weight loss of 7 to 10%. Achieving this level of weight reduction can even lead to the regression of fibrosis. The most effective approach combines at least 150 minutes of moderate exercise per week with a hypocaloric Mediterranean-style diet. For patients with a body mass index over 35 who struggle to meet these goals, bariatric surgery stands out as a highly effective option for inducing durable remission. For patients with moderate to advanced fibrosis who need more than lifestyle changes, 2 pharmacotherapies with distinct mechanisms offer new hope. Resmetirom, a liver-directed thyroid hormone receptor beta agonist, has been shown to resolve MASH and improve fibrosis without requiring significant weight loss. It also provides the added benefit of lowering LDL cholesterol. Alternatively, subcutaneous semaglutide, a GLP-1 receptor agonist, achieves similar liver improvements largely through significant weight loss and better glycemic control. The choice between these 2 agents allows clinicians to tailor therapy based on the patient's specific comorbidities, such as choosing semaglutide for those needing weight management or resmetirom for those with severe dyslipidemia.